I have the honor to present my dear colleague and friend, Professor Tamer Elsherbiny. He's assistant professor in our Department of Endocrinology, Alexandria University. He will present the third choice for the treatment of a Graves patient or patient with Graves disease, the surgical line of treatment. Please go ahead, Tamer.
Okay, so thank you all for hanging up with us for this long. This is the last presentation. We are going to discuss the last option available for a patient with Graves' disease. So this is me, an endocrinologist, talking about surgery as a definitive treatment for Graves' disease. Mentioning thyroid surgery, we have to pay respect for the memory of Dr. Rafik. Dr. Rafik was one of the greatest head and neck surgeons in Alexandria University who has passed away only 2 weeks ago. So we must pay respect for him. The agenda for today's presentation, I'm going to revise with you currently real life practices, and then I'm going to show you how the current clinical practice guidelines recommend the place for surgery. And then we are going to discuss rapidly the indications and contraindications for surgery as a solution for Graves' disease. And then we are going to view the preferred surgical techniques for a patient that's going to perform surgery for Graves' disease. And finally, some clinical tips to minimize the risk of complications of surgery. So I'm going to start with the first point in the agenda, the current practices, and I'm going to give you this polling question. Put it on May. So my question is actually to survey your practices. So in your practice, how many Graves patients would you recommend surgery as an initial treatment? May, are you with us?
Okay. Yes, doctor, I am.
Actually, I'm actually surveying your practice. This is not right or wrong question. So in 30 minutes, we are going to know how would you approach your patient regarding surgery. Okay, so most of you has gone for the lowest ratio, and actually this is much more similar to what I'm going to give to you. So if this is a patient with Graves' disease who is consulting his physician about the treatment of Graves' disease, so most probably the chance that he would advise surgery as an initial treatment for Graves' disease is going to be only 1%. And actually, this is the same situation if he is going to be a European patient visiting a European physician. So in the year 2011, they had this survey of clinical practice. These were members of the Endocrine Society, the American Thyroid Association, and the American Association of Clinical Endocrinology. As you can see, this was more than 400 practitioners in North America, about 100 practitioners in Europe, and you can see that they would advise surgery as an initial treatment for a patient with Graves' disease in only 1% of their patients. This was in 2011. Another survey was done in Europe in 2013, and they got a much similar answer. So only 2% of the practicing physicians would advise surgery as an initial treatment for Graves' patients. And this survey included about 150 physicians. 1 year later in France, and this included a much higher number of practicing physicians, almost 265. And you can see that up to 6% of practicing physicians would advise surgery as an initial treatment for a patient with Graves' disease. And the last survey was done in Italy in 2015, and you can see that it is 5%. That's the percentage that they would advise a patient to go for surgery as an initial treatment for Graves. And actually, this was the most extensive survey because it included almost 1,000 practicing physicians in Italy. And so my next question would be, which of the following factors may influence your decision to recommend surgery for a patient with Graves' disease? So is it active Graves' orbitopathy? Is it intention for pregnancy? Is it being a child patient? Or is it being the patient preference? So would these points alter your recommendation for surgery for a patient with Graves' disease? Also, it is only a survey of practice. It is not a right or wrong question. Okay, May? Give it to us. Okay, so the list goes for a child, but the answer is almost equal for the remaining options. So going back to the Italian survey, okay, no, going back for the American survey, you can see here that when the patient had ophthalmopathy at the time of presentation, up to 20% of the patients were advised to go for surgery as an initial treatment for Graves' disease. So it is a 1 in 5. Also, if the patient has given the intention that she is seeking fertility in the coming 6 months, actually 20% were advised surgery as an initial treatment for Graves' disease. So having active ophthalmopathy and having a near intention to get pregnant actually has increased the recommendation for surgery as an initial treatment for Graves' disease to 20 times more common. In the Italian survey, the presence of active Graves' orbitopathy increased the recommendation from 5 to 30% of the patients. That means 1 in 3 would be recommended to go for surgery if at initial the time of presentation, the patient had active Graves' orbitopathy. And the intention of pregnancy in the coming 6 months has also modified the practice, was almost 55% of the patients were advised to undergo surgery to meet their intention for pregnancy, which means that 1 in 2 would be advised to go for surgery if they had given their intention that they are planning for pregnancy in the coming 6 months. Okay, so for the current guidelines, where does the surgery come at the order of treatment of Graves' disease? So my third question, in your opinion, how would you order lines of treatment for Graves' disease? So would you start medical and then consider radioiodine and then consider surgery? Would you start medical and then consider surgery and last to consider radioactive iodine? Would you consider surgery as the first option? Would you consider radioiodine as the first option, as do Americans? So please vote. Okay, man, give it to us. Okay, so it is medical, then radioiodine, and then surgery. And the next was most of the voting would be medical, then surgery, then radioiodine. I would actually go for the first one. This is my practice with my patients, and so we would see that actually, according to the European Thyroid Association in 2018, they did not recommend surgery as the first line of treatment. And so they said that in patients with newly diagnosed Graves' disease, they all should be treated with antithyroid drugs. And they mentioned radioactive iodine ablation or thyroidectomy may be considered in those who prefer the approach. Definitely, it is not the first line of treatment. And then in another recommendation, if the patient with Graves' disease becomes hyperthyroid after completing a first course, which is called the relapse, definitive treatment with radioactive iodine or thyroidectomy is then recommended. And so surgery here may be the second or maybe the third line of treatment. While the Americans in 2016, they have given the recommendation as if we have three equal choices. So in a patient with overt Graves' hyperthyroidism, he should be treated with one of the following modalities: radioactive iodine ablation, antithyroid drugs, or thyroidectomy, and this was a strong recommendation. They did not prefer one line over the other. However, if you read the order, how did they write the order? They mentioned radioactive iodine therapy because actually this is the treatment of preference for them, and then they mentioned the antithyroid drugs, and then they mentioned thyroidectomy as the last option. Actually, this is how the Americans prefer the approach to Graves' disease. So they are apparently equal options, but they actually prefer radioactive iodine ablation. So the advantages of surgery is rapid control of hyperthyroidism. This is the most rapid control of hyperthyroidism. For antithyroid drugs, it would take months. For radioactive iodine ablation, it would take weeks to months. And so the most rapid control of hyperthyroidism would be in favor of surgery. There is no recurrence of goiter, no recurrence of hyperthyroidism if you choose the right procedure. There's no detrimental effect on the course of Graves' ophthalmopathy, which is unlike radioactive iodine ablation, which may exacerbate or cause a new onset Graves' orbitopathy. There is no radiation risk associated with surgery. However, there are certain disadvantages that we have seen today, like risks related to the surgery, risks related to anesthesia, like postoperative hypoparathyroidism, which may be permanent in some patients, the recurrent nerve palsy, the very high cost of surgery, especially in our country, the need for hospitalization also comes with a cost. And the least of our problems would be having a permanent scar. And I wouldn't agree that one of the disadvantages of surgery would be permanent hypothyroidism, because this is intended to occur. So what would be the indications to advise surgery for my patient? First, it would be patient's preference. However, it should be a well-informed preference until contraindicated, which means that you have to give your patient the option to choose from antithyroid drugs or radioactive iodine ablation or surgery. Sometimes a surgeon may mention to the patient that you only have to choose surgery and all the other options are not valid, which is not a well-informed preference. So if the patient prefers, mentioned in the European Thyroid Association guidelines. A second point, which may prefer surgery in this patient, if the patient has coexisting hyperparathyroidism requiring surgery. This was recommended by the American Thyroid Association. If you have definite malignancy or high suspicion of malignancy, if thyroid malignancy is documented or suspected based on cytology, or if you have a large thyroid nodule, especially if the nodule is greater than 4 centimeters, or we have a non-functioning or hypofunctioning on iodine scanning or technetium scanning, which would be called a cold nodule. A large cold nodule may have or may carry large suspicion of malignancy. If the patient is having symptomatic compression, especially in large goiters who is greater than 80 grams in weight. Graves' orbitopathy, patients with moderate to severe active Graves' orbitopathy. Intolerance or a contraindication to the use of antithyroid drugs, and those who present with major adverse reactions to antithyroid drugs. A patient who is planning pregnancy in less than 6 months, provided that thyroid hormone levels are normalized before surgical intervention. And the European Thyroid Association has recommended that thyroidectomy is the primary definitive therapy in childhood, but in post-pubertal children, radioactive iodine may be considered. And then we go for the contraindications of surgery. The contraindications of surgery include substantial comorbidity, such as cardiopulmonary disease, end-stage cancer, or debilitating disorders. Lack of access to a high-volume thyroid surgeon. This should discourage surgery for your patient. Patients who have previously operated necks or externally irradiated necks, because this is going to be a hell of a surgery. Pregnancy is a relative contraindication. pregnancy should only be used in circumstances where rapid control of hyperthyroidism is required and antithyroid medications cannot be reduced. You have to remember that in thyroid surgery in pregnancy is associated with higher rates of complications, including the hyperparathyroidism and recurrent laryngeal nerve injury. If you would go for thyroidectomy during pregnancy, you should avoid it in the first trimester of pregnancy because it carries the risk of teratogenicity associated with anesthetic agents, and there is also a risk of fetal loss if you operate in the first trimester. If you operate in the third trimester, there is risk of preterm labor. So optimally, if thyroidectomy is to be performed during pregnancy, it is going to be performed in the second trimester. However, it is the safest time, but it is not without risk because up to 5% of these patients would have the risk of preterm labor. Old age is a relative contraindication for surgery because older patients may have atrial fibrillation, may have heart failure, or may have ischemic heart disease. What about the technique? Is it hemithyroidectomy? Is it subtotal thyroidectomy? Or is it near total or total thyroidectomy? Based on the recommendation of European Thyroid Association, if surgery is selected, total thyroidectomy is the procedure of choice. According to the American Thyroid Association, if surgery is chosen for Graves' disease, near total or total thyroidectomy is the procedure of choice, a strong recommendation. And even in children, according to the American Thyroid Association, if surgery is chosen as a treatment for Graves' disease in children, total or near total thyroidectomy should be the procedure of choice. So if you are going to proceed, you are going to proceed with total thyroidectomy. The final part of the presentation is how to minimize the risk of complications. So my last question in the presentation, which of the following factors is essential for a better surgical outcome? Would it be an expert surgeon? Would it be an euthyroid status? Would it be evaluation of vitamin D status or the preoperative use of potassium iodide? Again, it is just to survey your opinion. It is not a right or wrong question. Okay, May?
Can you see the results? Yes, yes. I shared the results. Can you see it?
No.
Can you see it now?
No.
It's 72%.
72% surgeon, yeah, sorry.
No. 72% choose an expert surgeon.
Okay. Maybe it is a technical difficulty, but anyway, it is my job today to show you what are the factors which would make difference if you choose surgery for your patient. So the first factor would be surgery should be performed by a skilled high volume surgeon because only such surgeon would minimize the risk of complications like hypoparathyroidism, laryngeal nerve palsy, wound infection, and hemorrhage. Actually, this was the recommendation by the European Thyroid Association. If you are going to operate, use total thyroidectomy, and it should be performed by a surgeon with high annual volume of thyroidectomies. And again, it was the same recommendation by the American Thyroid Association. If you are going to operate, and then the surgery should be done by a high volume thyroid surgeon. The second point would be that hyperthyroidism should be adequately controlled by antithyroid drug treatment prior to surgery. This is going to minimize the risk of intra and post-operative exacerbation of thyrotoxicosis. This was recommended by the European Thyroid Association. Euthyroidism should be restored by antithyroid drugs before surgery. And again, it was the same recommendation by the American Thyroid Association. Patients should be rendered euthyroid prior to the procedure with antithyroid drug pre-treatment, and this was a strong recommendation. The third point, which was discussed previously by Professor Dr. Samir Naim Asad, which would be the vitamin D deficiency. So vitamin D deficiency should be corrected prior to surgery to reduce the risk of postoperative hypocalcemia. Actually, this was a European recommendation. Vitamin D deficiency should be corrected to reduce the postoperative risk of hypocalcemia. And again, it was the same recommendation by the American Thyroid Association, which recommended that calcium at 25 hydroxyvitamin D should be assessed preoperatively and replaced if necessary or even given prophylactically, as mentioned by Professor Dr. Samir Naim Asad, and this was a strong recommendation. The fourth point is that the use of a saturated solution of potassium iodide, SSKI, is helpful in the immediate preoperative period. This refers to to the last 10 days before the surgery. This is going to decrease thyroid vascularity, and so it is going to decrease intraoperative blood loss. And so this was recommended by European Thyroid Association. And again, it was recommended by the American Thyroid Association, which was considered to be a strong recommendation. Only a technical remark, we have two sources of potassium iodide. So you can give your dose as 5 to 7 drops of low gold iodine, which contains only 8 milligrams of iodide per drop, or only 1 to 2 drops of SSKI, which contains 50 milligrams of iodide per drop. This is going to be given 3 times daily, mixed in water or juice for 10 days before surgery. The last of the points that is going to minimize the complications of the surgery, if you have a patient that is going to be thyroidectomized, and it must be performed before an adequate control of hyperthyroidism. So in addition to giving him antithyroid drugs, you should give him beta blockade, you should give him glucocorticoids, and you should give him potassium iodide, which may help minimize the complications. This was a recommendation by the American Thyroid Association, which has mentioned that in exceptional circumstances, when it is not possible to render the patient euthyroid before the thyroidectomy, or the need for thyroidectomy is urgent, or the patient is allergic to antithyroid drugs, so patient should be adequately treated with beta blockade, potassium iodide, glucocorticoids, maybe more or less cholestyramine in the immediate preoperative period. And the surgeon and the anesthesiologist should be aware of this situation. So my key messages in this presentation is patient preference, desire for pregnancy, compressive symptoms, malignant or suspicious nodules, active Graves' orbitopathy are important indications for surgery. While, again, the same point, patient preference, old age, comorbidity are important contraindications for surgery. Near total or total thyroidectomy is the procedure of choice. High volume surgeon is a must. Achieving euthyroidism, vitamin D repletion, plus or minus giving a potassium iodide is a preoperative must. Okay, so thank you for listening. This was the last of my presentation. I invite you to follow up the Alexandria Thyroid Association Facebook page to be aware of the coming events, inshallah. And again, a recording of this webinar and the previous webinars, the previous 3 webinars, is actually available through our Alexandria Thyroid Association YouTube channel. So we would be happy if you follow and subscribe the Facebook and the YouTube. Thank you.